Hi there, I'm a PsychnP and I have 26 test questions for you on lithium. Ready? Let's learn psych fast. Question 1. Which of the following conditions might enhance lithium reabsorption in the kidneys? A. Excessive exercise. B. Febrile illness. C. Water restriction. Or D. Congestive heart failure. The correct answer is D. Congestive heart failure, and here's why. CHF, congestive heart failure, can lead to sodium and volume depletion in the body. When the body is depleted of sodium and fluids, the kidney responds by trying to retain as much sodium water as possible. This response can inadvertently lead to increased reabsorption of lithium in the kidneys, contributing to lithium accumulation in the body. Now let's go over the incorrect options. Option A, excessive exercise. Well, while excessive exercise can lead to dehydration and electrolyte imbalances, it's not specifically associated with enhancing lithium reabsorption in the kidneys. Option B, febrile illness. Well, febrile illness or any illness associated with a fever can lead to dehydration, but it doesn't directly enhance lithium reabsorption in the kidneys. And in option C, water restriction. Similar to the previous options, water restrictions impact lithium levels, but doesn't directly enhance lithium reabsorption in the kidney. Question 2. What can lead to excess intake of lithium? A. Excessive sweating. B. Low sodium diet. C. Chronic therapy. Or D. Water restriction. The correct answer is C. Chronic therapy. This is because chronic therapy refers to the long-term administration of lithium as treatment for conditions like bipolar disorder. Patients who are on long-term lithium therapy may sometimes unintentionally take excessive amounts of medication due to various reasons such as forgetting a dose and then doubling up on the next dose, or a misunderstanding dosage instruction, or improperly adjusting their own dosage without medical guidance. Now let's go over the incorrect answers. Option A, excessive sweating. While excessive sweating can lead to dehydration and potentially affect lithium levels, it's not a direct cause of excess intake of lithium. Option B, low sodium diet. Low sodium diet, it may affect lithium levels, but it doesn't directly cause excessive intake of lithium. And then D, water restriction. It's similar to the low sodium diet. Water restriction can impact lithium levels, but it's not a direct cause of excess intake of lithium. Question 3. Chronic therapy with lithium can precipitate which condition? A. Hypertension. B. Nephrogenic diabetes insipidus. C. Hyperthyroidism. Or D. Renal failure. The correct answer is B. Nephrogenic diabetes insipidus. So here's why. Chronic therapy with lithium is known to have adverse effects on the kidney function. One of the complications associated with long-term lithium use is nephrogenic diabetes insipidus, NDI. So NDI is a condition where the kidneys are unable to concentrate urine properly, leading to excessive urination and thirst. Oh, here's a mnemonic named Lithium that will help you remember the side effects of the drug. Now let's go over the incorrect options. Option A, hypertension. Well, hypertension can be a side effect of lithium therapy in some individuals. It's not directly precipitated by the chronic therapy with lithium. Option C, hyperthyroidism. Chronic lithium therapy can affect thyroid function, but it doesn't directly precipitate hyperthyroidism. And then option D, renal failure. While chronic lithium therapy can have adverse effects on kidney function, it typically doesn't lead directly to renal failure unless toxicity reaches severe levels. Question 4. Which of the following drugs might inflict chronic toxicity by reducing glomerular filtration rate? A. Diuretics. B. Anticoagulants. C. Antidepressants. Or D. Antihistamines. The correct answer is A, diuretics. So diuretics are medications commonly used to increase urine production and promote the removal of excess fluids and salts from the body. Some diuretics, particularly loop diuretics like furosemide, can reduce the GFR by affecting the function of the kidneys. A decreased GFR can lead to impaired kidney function, potentially contribute to accumulation of substances like lithium in the body, thereby increasing the risk of toxicity. Now let's go over the incorrect options. Option B, anticoagulants. Well, they are medications to prevent blood clot formation. They do not typically affect the GFR or kidney function in the same way as a diuretic would. Option C, antidepressants. They can have a side effect on kidney function, but they do not primarily reduce GFR and are not typically associated with chronic toxicity in this manner. Then option D, antihistamines are medications used to treat allergy symptoms, and they do not significantly affect the GFR or kidney function the same way as a diuretic would. 5. How might sodium and volume depletion affect lithium concentration in the serum? A. Increase lithium excretion. B. Decrease lithium reabsorption. C. Decrease lithium excretion. Or D. Have no effect on lithium levels. The correct answer here is C. Decrease lithium excretion. So sodium and volume depletion, which can occur during conditions like vomiting, diarrhea, or congestive heart failure, can lead to dehydration and electrolyte imbalances in the body. In response to dehydration, the kidneys try to conserve water and electrolytes, including lithium. This conservation mechanism can result in decreased excretion of lithium in the urine, leading to higher lithium concentrations in the bloodstream, potentially increasing the risk of lithium toxicity. Okay, let's go over the incorrect answers. Option A, increased lithium excretion. Sodium and volume depletion actually lead to decreased excretion of lithium rather than increased. When the body is dehydrated, the kidneys conserve water and electrolytes, including lithium, rather than excreting them. Option B, decreased lithium reabsorption. Again, sodium and volume depletion do not directly affect lithium reabsorption in kidneys. Instead, they primarily impact lithium excretion. D, have no effect on lithium levels. Now, sodium and volume depletion can indeed affect lithium levels by decreasing excretion and increasing serum concentration. So that option's incorrect as well. Question 6. Which factor might not lead to impairment in lithium secretion? Is it A, renal insufficiency, B, exercise excessively, C, diarrhea, D, excessive sweating? The correct answer is D, excessive sweating. So excessive sweating can lead to fluid and electrolyte loss from the body, including sodium and potassium. But it does not directly impact lithium secretion. Sweating primarily affects the balance of water and electrolytes in the body's extracellular fluid compartments, while lithium secretion is primarily regulated by kidney function. All right, why are the other options incorrect? Option A, well, renal insufficiency or impaired kidney function can lead to impairment in lithium secretion. The kidneys play a crucial role in filtering and excreting lithium from the bloodstream. So any impairment in renal function can also affect lithium clearance. Option B, excessive exercise. While excessive exercise can lead to dehydration and electrolyte imbalances, it does not directly impair lithium secretion. However, it can indirectly affect lithium levels by impacting hydration status. Then option C, diarrhea. Well, diarrhea can lead to fluid electrolyte loss, similar to excessive sweating, but it does not directly impair lithium secretion. Like sweating, it primarily affects the balance of water and electrolytes in the body's extracellular fluid compartment. Question 7. Which of the following statements regarding lithium absorption is true? A, lithium absorption is slow. B, lithium is extensively metabolized in the liver. C, its bioavailability is typically low. Or D, lithium absorption is rapid. The answer is D. Lithium absorption is rapid. This is accurate because lithium exhibits swift absorption once ingested, a notable characteristic essential for its therapeutic efficacy, particularly in treating mood disorders such as bipolar disorder. Its rapid absorption ensures a relatively quick onset of action, which is crucial in the clinical management. Now let's go over the wrong ones. Option A, lithium absorption is slow. This statement is erroneous. Unlike medications with delayed absorption kinetics, lithium is known for its prompt uptake into the bloodstream post-ingestion. Option B, lithium is extensively metabolized in the liver. This is false. Contrary to many pharmaceutical agents metabolized extensively even by hepatic enzymes, lithium undergoes minimal hepatic metabolism. Instead, its primary mode of elimination involves renal excretion without significant metabolic alteration. And then option C, its bioavailability is typically low. This statement is inaccurate. Lithium boasts high bioavailability, often approaching 100%. This signifies that a substantial portion of administered dose reaches systematic circulation intact, underscoring its predictable pharmacokinetic profile. Question 8. Why might patients with significantly elevated serum levels be asymptomatic? A. Lithium is metabolized quickly by the liver. B. Lithium levels do not reflect its intracellular concentration. C. Lithium primarily accumulates in the brain. Or D. Serum levels of lithium accurately represent its intracellular concentration. The correct answer is B. Lithium levels do not reflect intracellular concentration. This statement is accurate as it underscores a fundamental principle in lithium toxicokinetics. While serum lithium levels serve as crucial clinical markers, they only reflect extracellular lithium concentrations. Despite elevated serum levels, patients may remain asymptomatic because lithium exerts its therapeutic and toxic effects primarily within the intracellular compartments, particularly within neurons. Therefore, a discrepancy exists between serum levels and intracellular concentrations, which explains why patients with markedly elevated serum levels may paradoxically display no overt symptoms. Now let's go over the incorrect ones. Option A, lithium is metabolized quickly by the liver. No, that's wrong. Unlike many medications, again, subjected to extensive hepatic metabolism, lithium undergoes minimal metabolic transformation in the liver, primarily being eliminated renally in its unchanged form. Option C, lithium primarily accumulates in the brain. While lithium does exert therapeutic effects within the brain, this statement is overtly simplistic and does not fully encapsulate its distribution throughout the body. Lithium accumulates in various tissues, including the brain, kidneys, and thyroid gland, with varying degrees of concentration. Option D, serum lithium levels accurately represents its intracellular concentration. As said earlier, serum levels provide only a glimpse into extracellular concentrations and do not faithfully really reflect intracellular levels where the lithium exerts its pharmacological actions. Question 9. Which organs are more susceptible to lithium accumulation? A. Liver, bone, and muscle. B. Brain and kidney. C. Thyroid, bone, and muscle. Or D. Brain and liver. The correct answer is A. The organs that are susceptible to lithium accumulation are the liver, bone, and muscle. And here's why. So lithium is known to accumulate in various tissues, and among things, the liver tends to harbor a notable concentration. Additionally, bone and muscle also exhibit a propensity for lithium accumulation over time. So understand these tendencies is crucial for anticipating potential toxic effects and guiding therapeutic management in patients receiving long-term lithium therapy. Now, the incorrect options, option B, brain and kidney, they are organs that are susceptible to lithium accumulation. As said before, the brain does indeed play a role in the pharmacological effects of lithium, but it's not the organ where lithium tends to accumulate the most. As for the kidneys, while again, they are crucial for lithium excretion, they are not the primary site of lithium accumulation. And option C, suggests that the thyroid, bone, and muscles are the organs susceptible to lithium accumulation. While the thyroid does indeed interact with lithium and may be affected by chronic therapy, it's not primarily a site of lithium accumulation. And similarly, while bone and muscle can accumulate lithium to some extent, they are not the organs most susceptible to this phenomenon. So option D, brain and liver. While the brain does interact with lithium pharmacologically, as said before, it's not one of the organs where lithium tends to accumulate to a significant extent. The liver, while it plays a role in drug metabolism, it's not, again, typically a major site of lithium accumulation. Question 10. How does lithium excretion vary between sweat, feces, and kidneys? A. Feces excrete the majority of lithium. B. Sweat excretes lithium more than the kidney does. C. The majority of lithium is excreted by the kidneys. Or D. Lithium excretion is equal among all routes. The correct answer is C. The majority of lithium is excreted by the kidneys. This statement accurately reflects the predominant route of lithium elimination, emphasizing the pivotal role of the kidney in lithium excretion. Approximately 95% of lithium is eliminated through renal excretion, underscoring the kidney's paramount importance in maintaining lithium homeostasis and preventing its accumulation in the body. Understand this renal clearance pathway is crucial for appreciating the factors influencing lithium toxicity levels and patients receiving chronic therapy. Now let's go over the incorrect ones. Option A suggests that feces excrete the majority of lithium. While a small fraction of lithium may be excreted via feces, particularly in cases of overdose or impaired renal function, the kidneys are the primary route of lithium elimination in most circumstances. Option B implies sweat excretes more lithium than the kidneys. While sweat does contain trace amounts of lithium and may contribute to elimination, the quantity excreted through sweat is minimal compared to renal excretion. Then option D, saying that lithium excretes equal amounts in all the different routes. No, the kidney, again, is the major player in this. Question 11. What is the typical serum elimination half-life of lithium? Is it A, 6 to 12 hours, B, 24 to 36 hours, C, 12 to 27 hours, or D, 48 to 72 hours? The correct answer is C, 12 to 27 hours. This statement accurately represents the typical range of serum elimination half-life observed for lithium. The serum elimination half-life refers to the time it takes for the concentration of a substance in the bloodstream to decrease by half after its peak concentration. For lithium, this typically ranges from 12 to 27 hours in most individuals. Understanding this pharmacokinetic parameter is crucial for determining dosing intervals and predicting the duration of action of lithium in clinical practice. Question 12. What risk is associated with lithium use during pregnancy? A. Increased risk of neural tube defects. B. Higher risk of preterm labor. C. Increased risk of congenital cardiac defects. Or D. Elevated risk of Down syndrome. The correct answer here is C. Increased risk for congenital cardiac defects. This statement accurately identifies the notable risk associated with lithium use during pregnancy. Lithium is classified as a pregnancy category D due to its potential adverse effect on fetal development, particularly with the increased risk of congenital cardiac defects such as Epstein anomaly. It's very important that you as a healthcare provider weigh the benefits of lithium therapy against the potential risk when managing pregnant patients with psychiatric disorders. Now let's go over the incorrect ones. Option A suggests increased risk of neural tube defects associated with lithium use during pregnancy. While certain medications are indeed associated with elevated risk of neural tube defects, lithium is not primarily implicated in specific adverse outcomes. Option B proposes a higher risk of preterm labor associated with lithium use during pregnancy. While preterm labor is a concern in some cases of maternal medication use, lithium's association with preterm labor is not as well established as its association with congenital cardiac defects. And then option D, elevated risk of Down syndrome associated with lithium use during pregnancy. Down syndrome is a chromosomal disorder, and lithium use during pregnancy is not linked to increased risk of chromosomal abnormalities. Question 13. What symptom might breastfeeding infants of mothers taking lithium exhibit? A. Jaundice and vomiting. B. Hyperactivity and irritability. C. Cyanosis, hypotonia, and lethargy. Or D. Excessive weight gain. The correct answer is C, cyanosis, hypotonia, and lethargy. So lithium freely does cross the placenta and is excreted into breast milk, exposing infants to the medications. Infants exposed to lithium through breast milk may manifest symptoms such as cyanosis, that bluish discoloration to the skin due to inadequate oxygenation, hypotonia, which is reduced muscle tone, and lethargy, excessive tiredness, or that lack of energy. So it's very important for you to monitor baby closely to see if there's any signs if the mother is breastfeeding while taking lithium. Now let's go over the incorrect options. Option A suggests jaundice and vomiting is a potential symptom in breastfeeding infants exposed to lithium. While jaundice and vomiting are common symptoms in infants, they are not typically associated with lithium exposure through breast milk. Option B, hyperactivity and irritability. Well, infants may exhibit these behaviors for various reasons, but not specifically linked to lithium exposure from breast milk. And option D, weight gain. While weight gain is a common concern in infants, again, it's not typically associated with lithium exposure through breast milk. Question 14. At what age is lithium typically prescribed for managing acute manic and mixed episodes? A, 12 and older, B, 7 or older, C, 18 or older, or D, 21 years or older. The correct answer here is 7 years or older. So that's the statement that reflects the age range at which lithium is typically prescribed for managing acute manic and mixed episodes in patients with bipolar disorder. It's important to start intervention early in patients who exhibit symptoms of bipolar disorder to effectively manage acute episodes and prevent potential complications. By initiating treatment as children as young as 7 years of age, healthcare providers can help mitigate the impact of the disorder on the child's development and overall well-being. Question 15. In which situation is lithium commonly prescribed off-label as adjunct therapy? A, schizophrenia, B, OCD, C, major depressive disorder, or D, ADHD? The correct answer here is C, major depressive disorder. While lithium is primarily approved for treating bipolar disorder, it's not uncommon for us healthcare providers to prescribe it off-label to supplement existing antidepressant therapy in patients with major depressive disorder who have not yet responded adequately to standard antidepressant treatment alone. Augmenting antidepressant therapy with lithium can enhance treatment response and improve outcome for patients with treatment-resistant depression. Let's go over the wrong answers. Option A, schizophrenia. While lithium is used in cases of bipolar disorder with psychotic features, it's not a standard treatment for schizophrenia. Antipsychotic medications are primarily used for the treatment of schizophrenia. Option B, OCD, obsessive compulsive disorder. While lithium has been studied in various psychiatric disorders, including OCD, it's not typically a first-line treatment for OCD. SSRIs and cognitive behavioral therapy are the mainstay treatment for OCD. Option D, ADHD, attention deficit hyperactivity disorder. While lithium has been investigated as a potential treatment for ADHD, it's typically not recommended due to the availability of many other medications that are well established to be effective in ADHD D. Management such as stimulants and non-stimulants. Question 16. How long is the recommended duration for sustaining lithium augmentation if a positive response is observed? Is it A, 3 months, B, 6 months, C, 9 months, or D, 12 months? The correct answer here is 12 months, 1 year. When a patient demonstrates a positive response to lithium augmentation, it's essential to maintain the augmentation therapy for an extended period to consolidate and optimize treatment outcomes. Sustaining lithium augmentation for 12 months allows for sufficient time to stabilize mood and minimize the risk of relapse in patients with mood disorders, particularly those with treatment-resistant depression. Question 17. What is the recommended duration for administering lithium augmentation if a positive response becomes evident? Is it A, 2 to 4 weeks, B, 4 to 8 weeks, C, 8 to 12 weeks, or D, 12 to 16 weeks? The correct answer here is A, 2 to 4 weeks. This statement accurately reflects the recommended duration for administering lithium augmentation if a positive response becomes evident. When a patient demonstrates a positive response to lithium, it's essential to maintain the augmentation therapy for a short period to assess its efficacy and tolerability. Administering lithium augmentation for 2 to 4 weeks allows for an initial trial period to evaluate the patient's response and determine whether the continuation of the augmentation therapy is warranted. Question 18. For stabilized patients, what dosing strategy might be considered to mitigate potential adverse effects of lithium? Is it A, multiple doses throughout the day, B, a single morning dose, C, single nighttime dose, or D, variable dosing schedule? The correct answer here is C, a single nighttime dose. Administering lithium as a single nighttime dose can help minimize adverse effects such as gastrointestinal upset, tremors, and cognitive impairment, as the peak serum concentration occurs during the sleep when the patient may be less aware of these effects. Additionally, consolidating the daily dose into a single nighttime administration can enhance medication adherence and simplify the dosing regimen for patients. All right, let's go over the incorrect ones. Option A suggests multiple doses throughout the day as a dosing strategy for lithium. While multiple doses may be appropriate for some patients, particularly those who are requiring more frequent dosing, maintain a stable serum level of lithium, it may also increase the risk of adverse effects and inconvenience for the patient. Option B, a single morning dose. While a single morning dose may be suitable for some patients, it may result in peak serum concentration during the daytime when the patient is more likely to experience adverse effects, which will potentially impact their daily activities and quality of life and then therefore affecting compliance. Then option D, variable dosing schedule. While variability in dosing may offer flexibility for some patients, it may also increase the complexity of the regimen and make it challenging for the patient to adhere to the prescribed treatment plan consistently. Question 19. Which of the following is not listed as a preferred augmentation agent for lithium? A, valproate, B, lamotrigine, C, risperidone, or D, sertraline? The correct answer is A, valproate. When a patient demonstrates an inadequate response to lithium treatment, clinicians may consider augmenting the regimen with other medications to enhance therapeutic effects. Valproate, also known as valproic acid or divalproic sodium, is one of the agents that are commonly used for augmentation therapy in patients with mood disorders. Valproate works by modulating neurotransmitter activity and stabilizing mood, making it a valuable adjunct treatment option for patients who do not achieve sufficient symptom relief with lithium alone. Let's go over the wrong ones. B, lamotrigine. While it is commonly used in the treatment of bipolar disorder, it is typically employed as a maintenance therapy rather than augmentation strategy. Additionally, lamotrigine augmentation is more commonly utilized with other mood stabilizers like valproate or carbamazepine rather than lithium. Option C, risperidone. While atypical antipsychotics such as risperidone are frequently used in the treatment of bipolar disorder, they are typically reserved for managing acute manic or mixed episodes rather than augmentation of lithium therapy. Then option D, sertraline. While SSRIs like sertraline are commonly used in the treatment of depression, they are not typically employed as an augmentation agent for lithium in bipolar disorder due to its concern for the rebound of induced in a manic episode. Question 20. How long is the recommended duration for gradual tapering of lithium? A, 1 month, B, 3 months, C, 6 months, or D, 12 months? The correct answer is B, 3 months. Gradually tapering lithium over a period of 3 months allows for a gradual reduction in dosage, minimizing the risk of relapse and withdrawal symptoms commonly associated with abrupt discontinuation of lithium. This gradual approach gives patients' bodies time to adjust to decrease in levels of lithium, thereby reducing the likelihood of rebound symptoms or mood destabilization. Question 21. What is the initial dosage recommended for lithium treatment in bipolar 1 disorder? Is it A, 200 milligrams, B, 400 milligrams, C, 600 milligrams, or D, 800 milligrams? The correct answer is C, 600 milligrams. When initiating lithium therapy, healthcare providers typically start with a dosage of 600 milligrams, as this dosage has been shown to be effective in achieving therapeutic serum levels while minimizing the risk of adverse effects. Starting with a lower dose may not provide sufficient symptom relief, while starting with a higher dosage may increase the risk for adverse reactions. Question 22. How many times daily is the initial dosage of lithium typically administered for bipolar 1 disorder? A, once, B, twice, C, 3 times, or D, 4 times? The correct answer is B, twice. Healthcare providers usually prescribe the initial dosage of lithium to be administered twice daily. This dosing schedule helps maintain consistent serum levels of lithium throughout the day and optimizing therapeutic effects while minimizing fluctuations in serum concentration that can lead to adverse effects or inadequate symptom control. All right, let's go over the incorrect answers. Option A, once a day. While some medications are administered once daily for convenience or adherence, lithium typically requires more frequent dosing to achieve and maintain therapeutic serum levels. Option C, 3 times a day. While 3 times a day dosing may be appropriate for certain medications, again, typically not standard dosing frequency for lithium in bipolar 1 disorder, and it may increase actually the risk of non-adherence and dosing errors. And then, of course, option D, 4 times a day, that most certainly will increase the likelihood of non-adherence and will be compromised the treatment efficacy. Question 23. What is the target serum concentration range for maintenance treatment with lithium in bipolar 1 disorder? Is it A, 0.6 to 0.8 milliequivalents per liter, B, 0.8 to 1.0, C, 0.8 to 1.2, or C, 1 to 1.5? The correct answer here is B, 0.8 to 1. When using lithium for maintenance therapy, healthcare providers aim to maintain serum lithium levels within a therapeutic range of 0.8 to 1. This range has been associated with optimal efficacy in preventing both manic and depressive episodes while minimizing the risk for adverse effects. Question 24. Why might a lower initial lithium dosage be prudent for a bipolar 1 disorder? A, to increase the risk of adverse drug reaction. B, to decrease the risk of adverse drug reaction. C, to increase the therapeutic effect. Or D, to decrease the therapeutic effect. The answer is B, to decrease the risk of adverse drug reaction. Initiating lithium therapy at a lower dosage helps mitigate the potential for adverse drug reactions such as GI upset, tremors, and cognitive impairment. So by starting with a lower dose, you, the provider, can assess the patient's tolerance and response to the medication before titrating to a higher dose, thereby minimizing the risk of adverse effect while optimizing treatment outcomes. Now let's go over why the other options are incorrect. Option A, this suggests that a lower initial lithium dose is prudent to increase the risk of adverse drug reactions. This is incorrect because the goal of starting with a lower dose is precisely to decrease the risk of adverse reactions, not to increase it. Option C, suggesting a lower initial lithium dose to increase therapeutic effect. Well, while a lower dose may indeed reduce the risk of adverse effects, its primary purpose is to assess the patient's tolerance and minimize adverse reactions rather than enhance the therapeutic efficacy. In option D, lower initial lithium dosage is prudent to decrease the therapeutic effect. However, the intention behind starting with a lower dose is not to compromise the therapeutic efficacy, but rather to optimize treatment outcomes by minimizing the risk of adverse effects and ensuring patient safety. Question 25. Which of the following symptoms would not be expected in the patient experiencing lithium toxicity? Is it A, severe nausea, B, polyuria, C, coarse hand tremors, or D, heart palpitations? Question 26. Which of the following statements about lithium monotherapy is true? A, it is effective in treating all variants of bipolar disorder. B, it is particularly effective in treating depressive episodes in patients with rapid cycling bipolar disorder. C, it is less effective in treating depressive or mixed episodes in patients with rapid cycling bipolar disorder. Or D, it is equally effective when administered concurrently with antidepressant medication. The correct answer is C. It is less effective in treating depressive or mixed episodes in patients with rapid cycling bipolar disorder. This statement aligns with what we discussed earlier about lithium monotherapy. It's less than ideal for patients with rapid cycling bipolar disorder, particularly when it comes to treating depressive or mixed episodes. So the statement itself is actually correct. But wait a moment. So it might cause confusion, I understand. This question asked for a true statement about lithium monotherapy, and this one is actually about its limitations, not its overall efficacy. So in the context of this question, it's incorrect because it doesn't directly address the efficacy of lithium monotherapy overall. Let's go over the other options though. A, it's effective in treating all variants of bipolar disorder. This statement's incorrect. While lithium is indeed an excellent mood stabilizer for many patients with bipolar disorder, it's less effective for those with rapid cycling variant, especially in treating depressive or mixed episodes. And then option B, it is particularly effective in treating depressive episodes in patients with rapid cycling bipolar disorder. This is incorrect. As discussed earlier, lithium monotherapy is actually less effective in treating depressive or mixed episodes in patients with rapid cycling bipolar disorder. Option D, it's equally effective when administered concurrently with antidepressant medication. Incorrect. In fact, the concurrent administration of antidepressant medication can decrease the efficacy of lithium rather than enhancing it. So while the statement in the question is correct in the broader context of understand lithium monotherapy, it doesn't quite fit the specific criteria of this question, which asked for a true statement about lithium monotherapy efficacy. All right, all done. Good luck on your test. I hope you really understand lithium. Go ahead and click on this video next to learn more about bipolar disorder.